basically, a lot of people worry that human factors is some politically correct nonsense. But hopefully I want to show you that it's absolutely vital to patient care and why it can make a massive difference. But on our unit was one of our porters. And I knew him slightly because we lived quite close together, and we had daughters about the same age, about 6 months, and we occasionally pushed our daughters on the swings together. So I knew him a little bit. He'd come in, query swine flu. It was actually all negative, his H1 tests, and it was actually pneumonia, but we'd treat him as swine flu. He needed to be intubated, put to sleep, his breathing taken over. It didn't need to be done like that. We had an hour, now 2 hours. I got that call, and that saved my career, saved my sanity, and saved my mental health. I got asked to go down and see someone different in A&E, and my involvement stopped. So I called the anaesthetic third on. She was superb. She'd just done her FRCA. Anaesthetist, they say it's the hardest exam ever. She'd had a viva when she got asked about this very problem that she was about to encounter. She had a consultant job lined up, and she'd done over about 3,000 intubations, never with a problem. She got asked to see this gentleman. She assessed him. There was no risk factors. His only risk factor was a beard. That's not beardists. It's just that is sometimes anaesthetic risk because you can't see what's underneath the beard. But there's no risks at all. What they didn't do was plan in case something would go wrong. Well, why would they? She never had a problem before. She spoke to the ITU-SHO. It was slightly awkward because they'd sort of had a date a few years ago and it hadn't gone very well, and they sort of didn't get on very well but sort of did, and there's some weird dynamics. So they didn't really chat about it. They didn't talk to the nurses on the units about what they're going to do. But they went to put this 32-year-old porter to sleep. They went to intubate. They couldn't intubate. That doesn't matter. What you do is you come out and start to bag. But they didn't do that. They carried on trying to intubate. They lost situational awareness. They lost recognition of what was going on. Eventually, they tried to bag, oxygenate through a bag valve mask. But they couldn't. In that situation, it's something we're all trained for, those of us who work in the acute sector. It's quite actually simple. You put a hole in the neck. But firstly, things have been delayed because there's no CO2 monitor. There was no prompts or checks to check they had the right equipment. So you couldn't tell there's a problem straight away. And then they lost track of time. Then lost situational awareness. Even though she had a viva on it a week previously, they panicked. Instead of doing that, they carried on trying to put the tube down. This porter had saturations of about 50% for about 30 minutes before they intubated. He recovered from his pneumonia, but he didn't recover his brain function. 3 months later, he died in a nursing home. The team got a letter from the patient's family. What do you think it said? Thank you. A whispered thank you. You embarrassedly whispered thank you. That's the letter we got. Thank you that you gave us an extra 3 months of life. Because if you hadn't have put him to sleep and taken over his breathing that night, he would have died that night, and it was true, he would have died that night. What do you think happened on the unit? This was 10, 12 years ago. We know what should have happened, but what happened? Nothing. Well, not nothing. Discussion that shit happens in medicine. It's a hard job. Got to learn from your mistakes. See, it's possible to cope with the mental stress that we go through in medicine, and we've got a hard job. It's possible to cope with it when we know there's nothing different which could have been done. But in this situation, something different could have been done, and that anaesthetist knew that. If things had been done differently, this patient would have survived, and that's hard to cope with. There's the primary victim, the porter, and his family. And the secondary victim is someone we forget about, and that's our staff. A brilliant, brilliant colleague. 6 years at medical school, 10 years training to become senior registrar in anaesthetics. Wasted, because she gave up medicine. She never put anyone else to sleep. This is why human factors is so important. Can I just say it gets a bit more cheery the rest of the talk, don't you? I saw it. I'm not gonna, it's not here, and you don't need to take citalopram 6 weeks before this talk, I promise you. Thomas Paine said, a long habit of not thinking a thing wrong gives it a superficial appearance of being right. I would say we're practicing medicine based on 1950s medicine, not on what's changed in the last 68 years. So what is human factors? Everyone's going on about it. I was saying in the break, I can't remember who, I wish Hunt would stop going on about human factors. I love the fact that he's going on, but I'm trying to convince my junior doctors to believe in human factors. And if only he would say it's a pile of bollocks, then my junior doctors would believe in it. But everyone's talking about it, but what is it? What is it? What is this politically correct nonsense? I want to talk about a case where everyone talks about these dreadful cases and how awful it was. I want to talk about a case which went brilliantly well and about how we did great. 78-year-old lady had gone out dancing. She was cool. It was ballroom dancing, not clubbing. She wasn't that cool. But she was still from Brighton, so she was pretty cool. She had a cardiac arrest at the King Alfred. That's our local leisure centre which has ballroom dancing. On a Thursday, £2.50 session if anyone's interested, but you don't look like the audience who would be interested. And she had a cardiac arrest. The ambulance got there, they did wonders. They did CPR, they got a return of spontaneous circulation. She was brought to me as the team leader. It was complex. She was on warfarin, and she had a number of fractured ribs. She had a haemothorax, so blood in her chest, which needed a chest drain while she's in ventricular tachycardia. I was team leading, and I was saying, stop CPR, let's shock, start CPR, you put the chest drain, all that was, but we got her back. We did brilliantly. But she had low blood pressure. And I asked for 4 units of blood. About half an hour later, I said, where's the blood? And it was really weird, because a cardiologist said something to me. Now, it was really weird, because it's a cardiac arrest school, and a cardiologist was there. Secondly, what was so weird, he was so friendly. I thought, you must be a geriatrician. He's like, no, I'm actually a cardiologist. Like, you're in the wrong profession, mate. He goes, it's really weird. It's like, Rob, half an hour ago, I told you that Lab phoned and said the group and save had been mislabelled. But I just didn't hear him. So did that make a difference? Well, let's carry on the story. I got the blood half an hour later. She went to ITU. She did brilliantly. She had 8 days in ITU, 6 days of renal replacement therapy. That's very, very expensive. But she did brilliantly. She left the hospital after 3 weeks after coming in and only had a month of community rehab. That's a story I dine out on. I dine out on the fact that I was putting a chest drain and was doing CPR. It's brilliant. We should be so proud of what we did. But could have we done better? Yes. If we got that blood in half an hour ago, her blood pressure wouldn't have been so low for so long. Her kidneys wouldn't have been so damaged. She may have only spent 5 days in ITU and had 3 days of renal replacement. She may have left hospital 2 weeks and only had 2 weeks of community rehab. So we could have done better, even though it's an amazing story. So let's look at why I didn't do so well. Because this is what human factors is about. Why didn't I do so well? So the traditional analysis to shout at me because you didn't care enough. Or if I was a registrar, it's because you're a registrar. No. Let's look. I did not hear him say the group and save got mislabelled. Why not? Why didn't I hear him? I was concentrating so hard on what was going on. Absolutely. So what could he have said to make me hear? Sorry. He could have said Rob. Yeah, he could have said Rob. That would have been fine. What else? Pardon? He could have asked. Absolutely. He could have said anything to get my attention. So he could have said, team leader, are you ready to receive information? Because that's what the pilots do. When they're on a plane, I want my co-pilot to say to the pilot, co-pilot, are you ready to receive information? Yes, I'm ready. Turn this knob right. I'm going for a piss. Can you repeat that back to me? I don't know what pilots do. I don't teach them to fly, by the way. Just saying. Someone got the joke. Thank you. Someone's been on human factors course, got the joke. Only one, but never mind. 2 now. So I need him to say, team leader, are you ready to receive information? And why didn't he? What was he worried about? The answer is he's worried about sounding like a knob.
You're the team.
Pardon? I'm the team, but he needs to say, team leader, are you ready to receive information?
Yeah, but the status.
Well, no, he needs to get my attention and say, are you ready to receive information? And he didn't, because he was worried about sounding like a knob. We are worried about this knob factor. We need to embrace our inner knobness. We need to not be, don't be a dick, but there's a big difference between being a dick and being a knob. Probably not going to get invited back much, but you need to embrace your inner knobness if you want to be safe. And he didn't. And he said something really clever about repeating it back. I want to tell you about 2 nights ago. I phoned up my Chinese takeaway. It always worries me when I phone them up and they say, hello, Rob. Makes me worry about my diet. But I asked for sweet and sour pork, Hong Kong style, not those horrible balls, egg fried rice and a quarter crispy Arab duck, 33, 48 and 72. And what did they repeat back to me? They repeat it back every single time. Do I think knob? No, I think that's bloody brilliant because I don't want a mistaken Chinese takeaway. And I've never got an incorrect order, even though my English is not the Queen's English, and often I'm not speaking to someone whose first language is English. But in medicine, when I ask the nurses to repeat it back, unless they've been in our courses and indoctrinated by this, what do they say? I was listening, you know. Or when I get my junior doctor to say, and can you repeat it back, they think, oh, you're a knob. There's more. Why did this problem happen in the first place? Why did it happen? Who's been on the front line and done a group and save? It's a few of us. Who's done a group and save at one hospital and then another hospital? Was it the same way of doing it? No! How many times have you ever made a mistake in doing group and save? It's been rejected by the lab. Yes, lots. But it's a simple thing. In my trust at the moment, I know we're inadequate, but you know, we've got to write, apologies that I'm from Brighton. I'm sorry. We've got to write the patient's name in Latin backwards, otherwise they reject it. It's obviously not true in case someone, you know, but it's different to Worthing. It's different to Chichester. It's different to Redhill. Why? It's madness. It's absolutely madness. I want to tell you, if I may, about a stag do I went on about 2 years ago. It was actually after I'd done a load of reviews. This is how you rock in life. In the morning, I looked at case reviews of treatment of high potassium. In the afternoon, I went to Swansea. I am living the dream. So, looked at a load of cases of high potassium. And the treatment should be the same. But we had a number of patients who were treated in variable ways. 50 units of Actab instead of 15. People tried to remember they hadn't, it's a standard prescription, but they got it wrong. We'd had patients who suffered. They had low sugar levels and brain damage because we didn't follow simple treatments. So I've gone to this meeting and I went to my mate's stag do. Anybody been to stag do? Yeah, of course you have. Anybody been to a second stag do? It's not when you're selfish and have two for the same wedding. It's when you've got divorced and about to have another stag do. And that's so much better because you can slag off the first wife. So we had a mate's stag do, and it was in, before I carry on, it was in Swansea. Is anyone from Swansea? They're not admitting it. Anyway, so it's in Swansea, and he'd met his partner in a Wetherspoons. It's not a classy mate. It's my mate from home. He met his partner in Swansea in a Wetherspoons pub. And apparently they'd drunk cocktails all night, and he said, I'm not condoning binge drinking, I'm just telling a story. Don't make a moral judgment on me. That's what I'm saying. And he said, I want to go drinking in Wetherspoons, we're going to do a pub crawl, but we all want to drink cocktails. So we rolled the dice, it was 6, we were going to drink Sex on the Beach all night. So got to about the 4th pub, and it was all great. Got to the 6th pub, and it was amazing. It's like, every single cocktail is identical. Absolutely identical. This is brilliant. I was looking at the barman. He was no expert mixologist at all. He was a spotty teenager who didn't give a shit, let's be honest. But I went up to him and I said, excuse me, sir, how is every cocktail identical? Because this is amazing. And he looked at me. Now, please. And he did something amazing, which has genuinely changed what I do. He said, well, it's easy. And he got out his Wetherspoon recipe cards. And he flipped over to number 6, Sex on the Beach. Anybody could follow this. 1, get jug. Now, I want you to go to Wetherspoon and get a cocktail and look at this. 2, fill ice to mark 1. 3, 2 shots of Archers. 4, 2 shots of vodka. 5, lemonade to point 2. 6, orange juice to point 3. They don't like binge drinking, sorry. 7, give to customer. 8, charge them. I looked at it, I said, can I have a look at that? And he looked at me. And then I ran. It was the most amazing invention ever. A prompt card on how to do simple things. It's genius. Every single Wetherspoon has the same one. Why in the NHS, when it comes to taking a blood sample, do we not have 1, write the name, 2, write date of birth, 3, write the hospital number, 4, send to the lab, 5, make sure, simple things to have stopped that problem originally. Why are we not having standardised operating procedures within the NHS? Why are we saying, oh, medicine's all individualised? We can decide how we treat high potassium. Bollocks, we can. It should be the same treatment. Why are we not learning from places, like the Wetherspoons? Why are we not learning from places like the Chinese takeaway? Insanity is doing the same thing over and over again, expecting different results. I know this is an HEE-sponsored event. I know we're all interested in learning. but we've got as much to learn from there as we've got to learn from there. This is the official definition of human factors. Please tell me what you genuinely think. Genuinely. In a word. Pardon? Any other words? Long. Yeah. It does. I don't really know what that means. I give a day course on this every month. I have no idea what that means. To me, it's this. It's about judgment, leadership, empathy. It's above the technical skills. Not trying to teach someone to intubate. It's about everything else around that. But this, to me, is a better definition. Learning how best to not bugger up at 2 in the morning despite being tired and overworked, working with people you may not like in a hospital which is under-resourced and full of hunt-induced rota gaps. That, to me, is what human factors is about. And that is what my hero says. I've been repeating the same mistakes in life for so long now, I may as well call them traditions. So what's the extent of the problem? We misdiagnose 15% of the patients we see. I see 300 people, well, not me personally, my team sees 300 people a day in A&E. 45 are going to be misdiagnosed. Not because we don't know stuff, but we don't know about how to make a diagnosis because that's not taught. Treatment errors. Even when we do know what to do, 10% of treatments are wrong. We made a diagnosis of high potassium. Should just follow a recipe or a prompt card, but we still cause damage in 1 in 10 patients. It's the third biggest killer. That is not acceptable. The impact is to the patient, to NHS because it's costly, but it's also to our staff. We've got a difficult job. We need to make it easier for ourselves. So haven't we changed already? Surely we have. Yep, in theatres they're doing the 2 surgical checklists. Problem solved. But it worries me. We had 7 never events in my trust. Wrong site surgery. Wrong site anaesthetic of a numbed limb. Wrong prosthesis. But in every single one of those never events, there was a beautifully filled out WHO checklist. It is not about a tick box, it's about a cultural change, and we've not got there yet. So what about more challenging places like an A&E department? Sorry, like my A&E department. That is where risk happens. It is very easy to talk about human factors with the anaesthetic world and the surgical world, because yes, the airline industry analogy works, because taking off is like the intubation, the operation is like the flight, the landing is like the extubation. Something like that, something like a ward, something like a community trust, something like a psychiatric hospital, GP surgery. That is much, much harder to bring in safety issues than just not simple, but simplified 1 patient at a time operations. So every environment has their challenges. Can we make a difference? So I've done what every educationist would say you shouldn't do. I haven't yet introduced my aims, but I will now. So I want to talk about the next half an hour, 20 minutes, or till I've got shut up. Why medication error happens, why medical error happens. Look at the cornerstones of traditional human factors, then in a wider context, and simple things we can do to make a difference. A lot of it is easy. A lot of it is common sense. But in the NHS, common sense is not that common. And it's also basic. So do them with excellence. You've all seen this. Professor Reason's analogy of, latent errors and there's holes in the gaps and then errors happen. But I want to talk about one, which happened recently. And you can look at errors thinking about the person model or the systems model. Is it my fault? Is it the whole systems model? Actually, it's always a combination of the two. I want to talk about a case from 2 weeks ago where I very, very nearly missed a fracture. And I'm going to talk about this story for the rest of my life because I'm so proud. So proud, even though I screwed up. So we do nights as consultants in A&E. I know it's rare, but it's good for the patients. It's not good for my long-term longevity, but it's good for patients. And at night, you're not as good as normally. You don't function as well. And I saw a lady with a query fractured neck of femur. Got an X-ray, looked at the X-ray, it was normal. So I said to my one of the HCAs, I said, can you please mobilise her? The thing I'm so proud of this is our HCA calls me Rob. He doesn't feel there's a hierarchy. He said, cool. He wants to do his nurse training. He said, can I have a look at the X-ray? I said, yeah, sure, go and have a look at it. And he came back and said, I know you're the consultant and stuff, but are you sure there's a fracture? I was like, I'm going to go and show him. I'm going to show him that the normal angulation of a femur, that's normal. I'm going to go and teach him. I had a look at the X-ray and there's an obvious, blatant fracture. What I'd done was she'd come in a week ago with a query neck of femur. She'd been sent for X-ray. That X-ray was normal. I'd sent her for X-ray and the new X-ray hadn't been loaded up. I'd looked at the X-ray the week before. He stopped me causing her massive pain and damage by having a flat hierarchy and being prepared to speak up. That is why I was so proud of that moment, even though I screwed up. And why? Well, do I need to be more careful? Yes, but it was 3 in the morning. I was exhausted and I had so much else going on. So possibly. You know, should I have a checklist for looking at x-rays? Possibly. Was there systems issues at stake? Yes, you could have a systems issue where the PACS system comes up and says in bold, not today's x-ray. That would have helped. And then we've brought this up, we've written to Philips to say, can you actually look at this? And we spoke at Philips conference about this. But the flat hierarchy prevented it, in my opinion. Medicine is full of risks. Atul Gawande. Please read his books, apart from the last one, which isn't as good as the first 3. The important question isn't how to keep bad physicians from harming patients, it's how to keep good physicians from harming patients. And that's our challenge. So how do we provide optimal care? Well, I think human factors is absolutely important. These are the factors: situation awareness, how we make decisions, work as a team, knowing the environment, communication, cognitive aids, calling for help and debriefing and learning. But underneath that is all this: values and behaviours of an organisation and looking after the key diagnostic tool, which essentially is us. So what is this situational awareness? What's it all about? We don't notice things which are obvious. We make assumptions which are not true. I want you in a minute to see your powers of concentration. I'm going to play a video and I want you to count the times that the folder gets moved. Please concentrate. Please take part in it. Don't just go, oh, it's going to be a load of rubbish. Please concentrate. If you don't concentrate, the whole thing won't work. So please concentrate to see how good your concentration is, because I guarantee you cannot count it correctly. So please prove me wrong and count the number of times it has been passed along.
Here's a quick test of your powers of perception. There are 2 red files and 2 green files. Count how many times this red file is passed from one person to another in the next 20 seconds. Ready? Start counting.
How did you get?
So how many times did they pass it?
I don't care. Hands up or stand up if you saw a danger mouse. Stand up if you saw a danger mouse. Now look round. About a third of you saw it. Let's watch it. Let's watch him. Only a third of you saw it. Where is he? He does come. It's not a lie. There's Danger Mouse. Now the reason I use Danger Mouse, not the gorilla, is he is an icon of 1980 TV and best mates with Penfold, who I look like. So that's why I use Danger Mouse. So, if a third of you saw it and 2/3 different, that's why you've got to embrace your inner knobness. You need to be a knob because you didn't see Danger Mouse. Oh, can we stop playing this yet? I'll say play when I'm ready. Sorry. Okay, but hands up if you got kids. Hands up if you know you've got kids. So there's a difference. This is key stage 1. Key stage 1 I want to play, so you should get this right. Oh. Can we play it, please? So, key stage 1. So I want you to count the times the letter F appears in the following phrase. Comes after E. How many did you get? 3, 4. Stop. Can you pause it there? Can you pause it there, please? Right. Hands up. Stand up if you've got 6. So 2 out of 50 of you passed the key stage 1 question, which my 5-year-old gets. When we come to it, is a lot of you would have missed the letters of and wouldn't have counted the... Didn't miss that? You missed that? You missed that? So you think you're good. You don't think you're going to be fallible, but you make mistakes. There's a great BMJ article when they asked doctors, do you think you're above average and do you think you make less mistakes than the average doctor? 99.2% of doctors think they're above average and 99.6% of doctors think they make less mistakes than the average doctor. That is the problem we've got. We don't realise we're fallible. So what's the answer? Realise you're fallible. Use your team. Have this flat hierarchy. Have a sterile cockpit so we can say, are you ready to receive information? Please speak up in case I'm making a mistake. Have your team to be your eyes and your ears because you're not perfect. Decision making is one of the hardest things in medicine. We've got cognitive limitations, type 1, type 2 thinking, biases, fixation errors. You know, this, I'm trying to do a whole day course in 45 minutes, but just want to touch on a couple of things. We've got loads of cognitive types, but the most dangerous is the unconscious incompetent. Those who don't know what they don't know. Now that's not your brand new doctor or nurse because they know they don't know much and they ask for help. It's your junior registrar or senior SHO who's just got MRCP Part 1 itis, who think they are better than they are because they don't know what they don't know and they're too confident. But also, don't be fooled by confidence. Confidence often hides insecurities. This is the Dunning-Kruger effect. Your confidence is nothing to do with what you know. Supremely confident twat. There's type 1 and type 2 thinking. Type 1 is when you jump to a conclusion. Sometimes it's necessary. Type 2 is methodically working it out. Talk about some of the problems with both of these. What about talk about type 1 thinking? Problem with biases. Talk about a clinical case. 6-year-old, this is a case for our clinical decision unit, our CDU. We call it the can't decide unit. It's where we move patients. When we don't really know what's going on. So we had a 6-year-old man who had loin pain. Previous kidney stones and blood in the urine. Diagnosis, kidney stones. So my SHO asked for the blood pressure, and it was 90 systolic. What do you think they asked next? Pardon? They asked for the nurse to repeat it. It was 96 systolic. She said, can you repeat it again? And then it was 104 systolic. So she wrote OB stable, diagnosis, kidney stone, transfer to CDU. We all know the answer. It was a ruptured AAA and they had a cardiac arrest on our ward. This is the problem with diagnosing. It's because we look for evidence of what we want. I want to play with a game with you. I want to write up a rule and see if you can work it out. I'm not going to show you the answer. There's only 3 words, or 4 words. So you'll be able to read my writing, hopefully. Right, I'm going to play a number game with you. I want to give you the first series of 7 numbers. You're then allowed 8 guesses, and I want you to come and tell me what the rule is. Okay? 2, 4, 6, 8, 10, 12, 14, 16, 18. Fantastic. Right, what's the rule? Counting twos. Everyone agree? You all agree? That wasn't the answer at all. The answer was it just goes up. What you all did was what my SHO did. She looked for evidence of what she thought it was. She didn't look for evidence of what else it could have been. That's called a confirmation bias. When we jump to conclusions, we have confirmation bias. There's loads of other biases. First decision maker bias. So if an ambulance man has said, impression drunk, we're going to carry on thinking they're drunk rather than they've got a cerebellar infarct. You all fell for a confirmation bias because you all looked for what you thought it was and you didn't challenge yourselves. That's why we make wrong diagnosis. There is multiple other biases. Fixation biases.
Clipboard on the dash like so. I'd like you to imagine someone stepped in front of the car and execute an emergency stop, retaining full control of the vehicle.
Okay.
Would you please pull away when it is safe to do so?
That's a fixation bias. Only can do one thing. This is a famous tweet from Susan Boyle. We're all Susan Boyle families secretly. This is the definition of too many tweets makes a twat. Susan album party. Somebody's got it. Susan's anal bum party. Just got to be careful. You can take a photo of that. Don't worry. Do you want to? No, it doesn't. Low oxygen levels after intubation. Everyone assumes it's bronchospasm, but actually, it's a case when we had the oxygen tubing had been pulled out and it actually was going through the wall air rather than wall oxygen. Type 2 thinking is how you methodically do the thinking, but there's problems with that. For example, we don't know what reduced risk of death by a third means when we don't actually understand statistics. We need to understand number needs to treat, number needs to investigate. Then there's this diagnostic decision-making, understanding Bayesian theory of medicine, that you start with a pre-test probability of what condition is, do a test, and then get a post-test probability. But that doesn't mean the test is accurate. It just helps us in our diagnosing. The next major tenet is team working. You've got the bystander effect, where people just don't, if you ask everybody, nobody interacts and nobody stands forward. The Ringelmann effect is when you've got more people in a team and so everybody puts less effort in. And you have the problem of people not wanting to speak up. Oh. Can we play this, please?
But an experiment is not a public opinion poll. It examines behavior under the pressure of social forces, as the experiment of Solomon Asch reveals.
The experiment you'll be taking part in today involves the perception of lengths of lines. As you can see here, I have a number of cards, and on each card there are several lines. Your task is a very simple one. You're to look at the line on the left and determine which of the three lines on the right is equal to it in length. All right, we'll proceed in this order. You'll give your answer.
Only one of the people in the group is a real subject, the fifth person with the white T-shirt.
Okay.
The others are confederates of the experimenter and have been told to give wrong answers on some of the trials. The experiment begins uneventfully as subjects give their judgments.
2, 2, 2, 2, 2, 3, 3, 3, 3.
But on the third trial, something happens.
2, 2, 2, 2, 2.
The subject denies the evidence of his own eyes and yields to group influence. Asch found subjects went along with the group on 37% of the...
So, 37% of the time, people don't speak up, when even it's something simple about the line of length. You've got all these KSS, HEE, leadership academies. We forget about followership and the importance of followership. It's not just leadership which is important, but it's training us how to be sensible, appropriate and safe followers and to speak up and to not just go along with the status quo, because sometimes that status quo is not correct. So what we do, we need a flat hierarchy. Before a patient comes in, give everyone permission to speak up, make everyone feel comfortable within the team. No environment team is equally important. That's my student room. But you need a well-slicked, well-run organisation. Communication. We forget about how important that is. We teach it about speaking to patients, but we don't teach it about speaking to each other. The closed loop, the Chinese takeaway, S-bar, brilliant. Situation, background, assessment, recommendation, but I call it S-bar, S-bar. The second S-bar being speak back and repeat. Make sure you've understood it. Use PACE. Fantastic tool to how to speak up. All these errors where people had spoken up, the errors wouldn't have happened. Check if people are ready to receive information. And then name badges. Has anybody got a trust? Let me just use your example. The one you've got here. Now, I've just had an eye operation, that's why I keep putting drops to my eyes. I'm looking at your name, but I can't read it properly. Your name, you've got a trust ID, I can't read it properly. It encourages perversion, because I'm squinting your breast there, and it's really wrong and naughty of me. For blokes down there, you've got, it's in your groin area. Again, that's wrong. There's only one group of NHS workers where I know every single patient, every single staff member's name. CCAN. They're all called Mark, but even the ladies are called Mark in CCAM. But it's brilliant. It's so clear. If we need to change a culture, just get sensible name badges, because unfortunately your name just failed me, because I can't know your names. And I'm English, so I find out your name. I automatically don't hear it, but I'm English, so I don't want to ask you again because it's a bit embarrassing. In theatres, you can't use the big name badges. We should write our names on our theatre caps so that we don't forget our names. It makes such a big difference. Cognitive aids are a big thing. Massive thing. We've got these prompt cards for multiple conditions, and I'll signpost you to where we kept them. It's based on the Wetherspoon prompt cards. Now that's one for rapid sequence induction. But they can cause problems if they don't improve the culture. But we need to get into a habit of getting good. And Aristotle said what we repeatedly do, excellence then is not an act, but a habit. And my greatest philosopher is David Beckham. He said, for every free kick that matters, I've practiced 1,000. So if you do 1,000 sedations and you only make one big difference, so what? Still is important. Changing the culture is really hard. When we try to bring on these prompt cards, seen these things. I've never seen any bad practice. Why do we need these cards? From an SHO, unconsciously incompetent. But this is what worries me. The RSI checks aren't needed from an IT consultant who was working on the unit when that porter died. And then when you've got it with people who do want to change, it's fantastic. And it empowers people. We need to learn to call for help. We need to be prepared to call for help. And also, we need to learn from our mistakes. And have this thing that people get frustrated by saying, oh, I don't really understand, reflections. Is that useful? No, it's bollocks, reflections. I want to tell you why reflections is so good and so important. It's the World Cup now. I'm a football fan. Anybody remember David Beckham's free kick against Greece to take us into the 2002 World Cup and then obviously go out in the group stages? And remember that? So for those who didn't, he had a free kick with 1 minute to go. We needed to get an equaliser against Greece to go to the World Cup. It was about 30 yards out. It was the most amazing free kick. We went mad. And he was interviewed that evening, and everyone thought, what a knob. In a bad way, not a good way. Because they asked him, David, how come you're so brilliant at free kicks? He said, well, when I was little, my dad bought me a goal in the garden. And I don't know why I'm doing the accent, because it's my accent, sorry.
You need to be a bit more squeaky.
Oh, sorry, okay. And I am a fan of David, but he said, I always had a crush on Posh Spice, but that's just group therapy, really. And anyway, so he said, my dad bought me a goal in the garden. When the sun came up, I went in the garden and practiced the free kicks, watched where the ball went, changed it, practiced. When it got dark, I went inside, because what's the point of practicing football in dark, because I can't get better? If we're going to learn from our mistakes, learn from our patients, we need to practice medicine in the light. Because when I refer a patient to the medics, I don't follow up to see if I was correct. When I discharge someone home, I don't phone them up in 2 days' time to see if I was correct, to see how they're doing. If we want to get better at improving our clinical gestalt, improving our clinical care, we need to follow David Beckham and practice medicine in the light. See what happens. Practice reflection. Practice clinical governance. Ataguani said, no matter what measures are taken, doctors will sometimes falter. And it isn't reasonable to ask that we achieve perfection. What is reasonable to ask is that we never cease to aim for it. So does this make a difference? Got 5 minutes, is that all right? Yeah, cool. There is evidence from data. Yes, there's loads of evidence. There's evidence from data, but clinical cases, I think, tell a greater story than a load of statistics. I want to talk about this case from Worthing. It was December 2014. It was big in the news at the time. A paper boy was knocked over on his Christmas rounds. But he came home in time for Christmas Day. And I'm going to tell you about the transition from there to there. He got called, and the HEMS team, the Harry Crotch emergency team, arrived. He needed to be intubated. They did it with a checklist. They used their communication skills. They know they're not perfect, so they get the police to read the drug out to make sure you're not going to make that error and not miscount the letter Fs. So a policeman was there standing saying, rocuronium. They said, that's correct, that's what we use. Because we know when we check ourselves, we make mistakes. They intubated with a checklist, and there's no problems. We got a phone call to say the patient's arriving. We got everything ready. And we noticed there was no suction tubing. So we got it ready before they arrived. We planned what we'd do. When he arrived, he was coughing. He was tube, he was coughing. That's bad for neurocare. So summary of I'm trained as a neuro-IT consultant, summary of it, keep blood pressure up, keep my oxygen level all right, and stop them coughing. That was 18 months of my life. Anyway, sorry to any neuro-anaesthetists, but it's true. We need to stop him coughing. So we gave him rocuronium, but we had it ready. He was saturating not great, but we had the suction tube ready to go, and we sucked out a load of gubbins. He needed to go to CT scanner. And we'd done a pre-transfer check, and there was no oxygen left in the cylinder. It wasn't a problem, because we checked, because we'd gone through that checklist. And we replaced the oxygen cylinder, and he went to the CT without any problems. He went up to London to be bolted, had a fantastic care, and did brilliantly. I remember I was presenting this to the Grand Round at Brighton, and we had one of the professors of rheumatology going, well, it's just a standard case. It's quite dull, really. I want you to come and talk about Anna and an amazing diagnosis. It may be dull to you, Professor Davis. Maybe it's dull to you. 15 years of frustration coming out. It may be dull to you, but it wasn't dull to my staff. It wasn't dull to the kid, and it certainly wasn't dull to the patient and our parents. And that's what's important. Because 99% of what we do is standardised care. Yes, you need 1% of inspiration, but 99% is perspiration of making the right things happen all the time. And that's where human factors work. And this was him on Christmas Day. If you ever want to run a resus, you need a shit-hard American resus nurse. And I said to the dad, look, mate, he was so grateful. We still stay in contact, and they know we talk about him the whole time, so it's got all permission. That's why there's a picture of the family there. Don't mind at all. This is not breaking confidentiality. I said to the dad, one of the things you may find is after a head injury, you get personality changes. He goes, Yeah, I know, he's so much less of an arsehole since his head injury. It was a great, great feeling to be part of that team, and human factors is what made it. So the case wasn't special. The standard care required no genius thinking and just safe team working, human factors, making sure the basics are done correctly. So how do we put this all together? You need a number of tacits. You need knowledge and technical skills. You need compassion. You need human factors. You need critical appraisal, knowing the evidence, understanding the evidence. And you need your resources. But you need all of that to provide that good care. And human factors is key to providing that safe care. In the long term, you need to work in an environment where everyone is treated well. Work in an environment where we look after ourselves and look at systems to see if we can iron out risks. But as a patient arrives, we need to brief before a patient arrives. We need to use prompt cards where necessary. Realise we're fallible and have this sterile cockpit attitude. And think about how we're making decisions. Know where your environment is. Plan for problems, don't just react to them. Work as a team, not a set of individuals. And communicate effectively. And embedding success is about debriefing all major events and learning from success as well as from failure. Having grey text forms, not just day text forms. Change the culture is the key. I used to worry about these laggards, the ones who would never change, but work with the innovators, the early adopters, the early majority, the late majority, and the laggards will come on board. Yes, you can use a stick and use a carrot. I think the carrot is better, and the carrot is improved patient care. And however much there is a laggard, they still care about their patients. But we need to become interested in human factors. And that's the very first success towards the very first step towards success in any occupation, to become interested in it. And we need to become interested in human factors. For my last slide, is there any questions? Because I just want to finish one slide, which I think is important. I'll come back to the question in a second, if that's all right. Sorry, is that a question? Sorry. Just want to play this one video. This is how you change a culture. You see this, I apologise. This is how you change a culture. If you're at a festival in Sweden, just turn up very slowly. The festival in Sweden, the thing to do is dance like a knob. He's doing the right thing. He's doing the human factors equivalent of saying, team leader, are you ready to receive information? He's using prompt cards. He's using checklists. He's got rid of his trust ID and realised that's a security badge and got a big yellow badge with black writing saying Mike. And he's doing the right thing. But at the moment, everyone's thinking, knob, I'm not joining in. But we need everybody to be dancing. What he needs is a true hero, someone to adopt. And this is where you come in. You need to say, actually, this is right. We need to copy. We need to imitate, and say, yes, you may look like a knob, but we're going to copy you. I'm not going to be embarrassed to say, team, are you ready to receive information? I'm no longer going to be embarrassed to say, and can you repeat that back? And that's when our hero comes in. He is the hero of human factors. He says, yes, I see what you're doing, I'm going to copy you because you're doing the right thing. But the question is, how are we going to get more people? We make it a social movement. We don't just force things down people's throats. We make it a social movement. Get people to want to do it. And then there's some early adopters. Now, how do we get that telegraph reader in the corner with a hat on dancing? He's got no interest. He's your surgeon. He says, I am God. I am God. Don't tell me what to do. But how do we get him? Because he doesn't want to listen. He doesn't want to listen to his HCA. But he needs to because he's only got 2 eyes and 2 ears. He's got a team. He doesn't want to know them. So we get the early majority. That's great. Can we just turn up very slightly because it's getting exciting. So they're dancing away. And you've got a social movement now. So how do you get that surgeon who's reading the Telegraph to dance? You make him feel like they're not for not joining the human factors revolution. You isolate him. You make him feel uncomfortable. You make him think that he's the weirdo. He's the knob. And we're going on and on and on. There he is, he's up! We have got the surgeon dancing, even though he doesn't want to because he feels uncomfortable by not dancing. That is how you change a culture. So when I talk about human factors, it is not easy. But why am I so passionate about it? It's because I still walk my daughter to school. And when I walk my daughter to school, her friend doesn't have a dad walking their daughter to school. That is why I'm passionate about this. Thank you very much. If you want to take a copy of this, we've run for a couple of years. HE have very kindly helped introduce human factors courses. We start with half days. We've now had 1,000 people from the region do a full day human factors course, and we've done them at a lot of trusts around the region. We're now obviously. HE have pump primed the courses, now we're running them locally, but I don't want them just to be about BSUH. So we are going to want other people to come. There will be a small charge because that's why you're going to self-fund them, because they're not HE funded anymore for people outside of BSH, but they're totally not profit-making, obviously. But if you email Amelia Annon, she will send you the details. All the resources that we've produced are all, we've got a 15-minute induction video, we've got an hour video of it, all our slides, all our prompt cards, all the key learning points are all from clinicalsafety.org. They're all free to download, so please take that. And finally, the other key thing about patient safety is about critical appraisal and understanding how to use the evidence, and we run courses on that, so that's the website if you're interested in there. But any questions, and thank you very much for listening. Thank you very much for inviting me. It's a pleasure to come.